Okay, so chapter 13 is shock. We're gonna just jump right into it. Shock can be difficult. But as we go through, we're gonna talk about how to think about it a little simpler. So we're gonna talk about the fundamental knowledge of causes, pathophysiology, and management of shock, respiratory failure and arrest, cardiac failure or arrest, and the post-resuscitation management. Um, The fundamental knowledge and pathophysiology of respiration and perfusion to a patient's assessment and management. So shock, it's also known as hypofusion. Um, it's defined as an inadequate cellular perfusion. Any compromise in perfusion can lead to cellular injury or death. In the early stages, the body attempts to maintain homeostasis. So anything that affects us being able to supply that oxygenated blood to the cells and tissue, um, the heart, anything that affects that will cause us to go into shock. The homeostasis is the ability of an organ to maintain a stable internal environment. Let's see. I kind of put two definitions on there, but diffusion. We've talked a lot about diffusion in previous chapters, like 11 and 16, the two airway chapters we did. Uh, Diffusion is a passive process in which molecules move from an area of higher concentration of molecules to an area of lower concentration. Oxygen and carbon dioxide move across the walls of the alveoli. The majority of oxygen is carried to the tissue attached to the hemoglobin, that red blood cell. Carbon dioxide can be transported in the blood from tissue back to the lungs in three ways. It can go dissolved in the plasma, combined with water in the form of bicarbonate, or attached to that hemoglobin. So carbon dioxide waste produced or products released from cells can combine with water in the bloodstream and become that bicarbonate. Once it reaches the lungs, the bicarbonate breaks down into carbon dioxide and water, and the carbon dioxide is exhaled. So all of that in one big picture is it's the same process we've been talking about when we talked about onloading oxygen, offloading carbon dioxide. It's just explaining that it can happen in multiple ways. In cases of poor perfusion, shock, um, transportation of carbon dioxide out of the tissue is impaired. Result It results in a dangerous buildup of waste products, which may cause cellular damage. Shock refers to the state of collapse or failure of the cardiovascular system that leads to inadequate circulation. So, like we've been talking about, if we're not feeding those tissues and cells, then we're going to have issues, right? And that starts with the cardiovascular system, and also includes our respiratory system. To protect vital organs, the body directs blood flow from organs that are more tolerant of low flow, such as the skin and intestines, to the organs that cannot tolerate low blood flow, such as the heart, brain, and lungs. This is known as shunting. So our body will constrict our vessels that go to anything that doesn't need constant blood flow and pushes all the blood to the main organs, your heart and your lungs, and your brain. Early recognition of the signs and symptoms of shock can save lives. Shock is life-threatening and requires immediate recognition and rapid treatment. Pale, cool, and clammy are going to be some of the main go-tos for noticing shock. So we've discussed it a little bit in class. If your patient's extremely pale, um, if they're cool to the touch, they're either going to be that clammy. It's almost weird. It's like a wet but sticky feeling. We need to recognize this as a form of shock. We're going to discuss a lot of multiple types of shock. The biggest point though is recognizing that there is shock and treating it immediately. Um, and we'll get into that treatment here in a little bit. So, your cardiovascular system consists of three parts. It's your heart, which is your pump, your pipes, which are your vessels and arteries, and then your content, which is going to be your blood or fluids. This we've seen this before in previous chapters, just the flow of blood through the body. Um, so we start there in your right atrium. We go down to our right ventricle. We go up into those, yeah, uh, pulmonary veins, or sorry, pulmonary arteries. We go to our lungs where uh, we pick up that oxygen at the alveoli and we kick out that carbon dioxide. We go back to our left atrium. We're pumped down into the left ventricle, and then it goes up to our aorta, um, and goes out through our body, feeding those cells and tissue. So right, right, lung, lung, left, left. The perfusion triangle, when the patient's in shock, one or more of these three parts is not working properly. So our heart, if something's wrong with it, we can have shock, blood vessels, and the blood. It's not just going to be just one of them though. So if the heart's not functioning right, we're not filling our vessels, so our blood's not circulating. There can be something wrong with just one of them. There can be something wrong with two of them. There can be something wrong with all three of them. We're going to have shock at this point. Um, we're kind of starving our body. So blood pressure is the pressure of blood within the vessels at any moment in time. We know that. So we know that the systolic pressure is the peak arterial pressure, the diastolic pressure in the arteries while the heart's at rest between beats. Pulse pressure is the difference between the systolic and diastolic. Um, it signifies the amount of force the heart generates with each contraction. A pulse pressure less than 25 may be a sign that patient's in shock. So we take our systolic minus our diastolic to get our pulse pressure. Blood flow through the capillary beds is regulated by the capillary sphincter, um, circular muscle wall that constricts and dilates. These sphincters are under the control of the autonomic nervous system, which regulates involuntary functions such as sweating and digestion. Capillary sphincters also respond to other stimuli such as heat, cold, the need for oxygen, the need for waste removal. Regulation of blood flow is determined by cellular need. Remember, we have all of these receptors and different um, parasympathetic system and the sympathetic system. We have all of this going on inside our body that we don't even control, like your autonomic nervous system, um, that your body will naturally do this for us. Perfusion, uh, perfusion also requires adequate oxygen exchange in the lungs, nutrition in the form of glucose in the blood, and waste removal primarily through the lungs. So we have to be able to diffuse that oxygen at the alveoli level. We we've talked about how important our glucose is and nutrition, and then getting rid of that carbon dioxide. Mechanisms are in place to help support the respiratory and cardiovascular system when the need for perfusion in vital organs is increased. Includes the autonomic nervous system and hormones. So the sympathetic side of the autonomic nervous system, which is responsible for fight or flight response, will assume more control of the body's functions during the state of shock. So it kind of steps in, takes over. This response by the autonomic nervous system causes the release of hormones such as epinephrine and norepinephrine. Hormones cause an increase in heart rate and in the strength of cardiac contractions, as well as vasoconstriction in non-essential areas, primarily in the skin and gastrointestinal tract, peripheral vasoconstriction. This response causes all the signs and symptoms of shock in a patient. So, excuse me, this is what we was talking about a second ago. Um, this is shunting. So our sympathetic nervous system is going to kind of take over, and we are going to constrict all the vessels and stuff in like our arms, our legs. And what it's gonna do is it's gonna force all that blood to kind of stay in the center section of us, in our heart, in our lungs, and our brain. That's why our skin will become pale. We don't have that constant flow of blood, like normal. We're gonna get that cool color or cool feeling because we're not cycling fresh oxygenated blood. So we are not metabolizing in that area. We're not producing that heat in our arms and legs. And then we're going to get that kind of sticky diaphoretic, that clammy to us also. So this right here is where it's actually taking place. Our body notices there's a problem, so it's going to dilate those vessels, release those hormones. So our heart's actually going to speed up and try to beat harder, but it's mainly feeding our core and our brain. You can only do that for so long, though, before other things start slowing down because it gets wore out. Um, so many causes of shock. There are, and we're going to go over them. You need to know them, but the most important thing is know how to treat shock. It's going to be more important um, to get to recognize shock and treat it. That's the biggest point. Many different shock forms. Three basic causes are a pump failure, poor vessel function, and low fluid volume. So pump failure causes heart attack, trauma to the heart, obstructive causes, large pulmonary embolisms, um, low fluid volumes causes trauma to weak vessels and tissue, fluid loss from GI tract, vomiting, diarrhea can also lower the fluid content of blood. And then poor vessel function. This is caused by infection, drug overdose, narcotics, spinal cord injuries, anaphylactic shock. But notice that it's the same three things every time. So pump failure, something's wrong with our heart. Uh, Low fluid, we've leaked out fluid, whether it was vomit, diarrhea, or bleeding, internal or external, or poor vessel function, whether we are constricting or dilating, and we shouldn't be. There we go. We kind of talked about some of this, but cardiogenic shock, obstructive shock, tension pneumothorax, cardiac tamponade, and pulmonary embolism. Poor vessel function, distributive shock, septic shock, neurologic shock, anaphylactic shock, psychogenic shock. Fluid is going to be hypovolemic shock, hemorrhagic shock, and non-hemorrhagic shock. And we're going to break these down here in just a minute. Cause of inadequate function of the heart, a major effect is the backup of blood into the pulmonary vessels, resulting buildup of pulmonary fluid in the pulmonary edema. This is cardiogenic shock. Cardiogenic shock, that heart is not pumping like it should, and we get that backup of blood. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. Cardiac output depends on adequate contractility of the heart. So that heart muscle, we've talked about how it needs to be able to flex. Um, when it can't do that properly, we've got an issue the amount of blood to pump or preload, and resistance to flow in the peripheral circulation after load. I should have put the definitions on there. They are in your book. Caused by a mechanical obstruction, obstructive shock is caused by a mechanical obstruction that prevents an adequate volume of blood from filling the heart chambers. Three of the most common examples is cardiac uh, tamponade, which is blood or fluid fills around the pericardium, putting pressure on the heart, not allowing its maximum pumping effectiveness. So that pericardium is that sac that goes around the heart. When fluid gets between it and the heart muscle, it takes away the ability for the heart to stretch open all the way. And so you're not getting that full preload um, before the heart compresses again. So you're going to get a decreased of blood pressure because you're not pumping the same amount out of the heart that you normally do. Tension pneumothorax is accumulation of air between the chest wall and the lung, leading to an increased pressure in the chest, placing tension on the lungs and heart and the great vessels. We talked about this a little bit in class. This is where air is escaping into the chest cavity and it's pushing into that lung. As soon as that lung collapses, it continues to build up pressure, and it's going to start putting pressure on the heart, the main vessels, um, and then at that point, uh, it's considered a tension pneumothorax as soon as it starts putting tension on other organs. Pulmonary embolism is a blood clot that blocks and stops blood flow to the arteries in the lung. So we already talked about this, but cardiac tamponade, a collection of fluid between the pericardial sac and the myocardial, uh, is called a pericardial infusion. If the infusion becomes large enough, it can prevent the vessels from filling with blood, the ventricles from filling with blood, a condition called cardiac tamponade. Once again, we are putting so much pressure on the outside of the heart that the heart cannot fully open to fill with blood. Um, it's caused by blunt or penetrating trauma that causes hemorrhage around the heart. Signs and symptoms of cardiac tamponade are referred to as Beck's triad. This will probably be a test or quiz question. The presence of jugular vein distension, muffled heart sounds, and narrowing pulse pressure, where the systolic and diastolic pressure start to merge. So we've talked a little bit in class about jugular vein distension. Those veins, the jugular veins, are actually going to be like popping out. You're going to be able to see them clear as day. Muffled heart sounds, you're going to listen, and instead of that clear, this thumping, it's going to sound like it's a long ways away. It's just kind of shallow. Well, you're hearing it through that fluid, so it muffles it really bad. Tension pneumothorax, we've talked about. Pulmonary embolism, blood clot that blocks the flow of blood through the pulmonary vessels. If massive, can result in complete backup of blood in the right ventricle, leading to catastrophic obstructive shock and complete pump failure. Distributive shock results when there's a widespread dilation of small arterioles, small venules, or both. The circulating blood volume pools in the expanded vascular beds. Uh, Tissue perfusion decreases. Septic shock occurs as a result of severe infection, in which toxins are generated by bacteria, or by infected body tissue. Toxins damage vessel walls, causing an increased cellular permeability. Vessel walls leak and are unable to contract well, so it weakens those vessel walls and will actually have fluid that leaks through those walls out into the body. which is also taking away from the fluid level that we need, but it spreads that infection. Widespread dilation of the vessels, um, in combination with plasma loss through the vessel walls results in shock. So if we dilate, we're opening up, right? Well, if we dilate, our heart's going to try to pump harder to keep that blood pressure high, but we don't have the same size of pipe anymore. So that blood will actually not be under pressure going through there. It's actually just gonna kind of be pooling in there. Um, so our blood pressure once again is going to drop. You're going to get that pale, cool, clammy skin. We're not actually pumping blood through the vessels at the same pressure that we're used to. And like it says, it will cause us that plasma and stuff will start to leak through those damaged vessels. So it's a fluid loss at the same time as that dilation, loss of blood pressure. So we will go into shock there. We're still not feeding our cells and tissue. Neurological shock, usually the result of high spinal cord injuries, muscles in the walls of the body's vessels, sorry, are cut off from the sympathetic nervous system and nerve impulses that cause them to contract. All vessels below the level of the spinal cord injury dilate widely, increasing the size and capacity of the vascular system, causing blood to pool. So we get a spinal cord injury, we get something like that. Anything under that, our brain is not able to communicate with it anymore. So that sympathetic nervous system is unable to control it anymore. So everything just opens up and dilates below the injury site. Um, so we have pooling that takes place because we're not at the same pressure that we should be. Um, the example I give in class is if I take a 4-inch fire hose and hook it up to my water hydrant at my house and I turn my hydrant on full, water's not going to shoot out the end, water's just going to run out the end. Whereas if I hook my garden hose to my water hydrant and turn it on full, water is going to shoot out the end because it's a smaller diameter, it's higher pressure. As we make that vessel larger, the pressure goes down. Now we're just going to run through. We're not shooting blood through that hose, if you will. Um, so our body is used to that garden hose. And so we've got high pressure pushing that blood through the body. As soon as everything dilates and we don't have control over it anymore, we're not shooting that blood through anymore. Now we're just kind of lazy river. We're just kind of it's just rolling through slowly because there's nothing there to push it. Um, okay, anaphylactic shock occurs when a person reacts violently to a substance to which he or she can be sensitized. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. Each subsequent exposure tends to produce a more severe reaction. So you could have been stung by a bee as a kid and as a teenager, and nothing happened. You turned red and it itched for a couple minutes, and you were fine. And now as an adult, you got stung by a bee and it swelled up and you got hives and now you're having trouble breathing. You're in anaphylactic shock. It's um so that is sensitization. You weren't sensitive to it before, but now you are. So signs and symptoms of anaphylactic shock. Um, there are a ton of them. The main ones we want to look for though is we want to look for that swelling, the blotchiness, the hives, and definitely, if we even consider anaphylactic shock, we need to be thinking about airway management immediately. ABCs become top of the line priority for this. Uh, Physiological shock. Um, Caused by a sudden reaction of the nervous system, produces temporary generalized vascular dilation, results in fainting or syncope. Um, Life-threatening causes include irregular heartbeat, and brain aneurysms. Non-life-threatening events include like receiving bad news, experiencing extreme fear, or unpleasant sights such as blood for some people. Um, Psychogenic shock is right up here. Um, a fainting goat is a perfect example of this. You surprise them, they pass out. Same thing. Some people do that. Some people see blood. If you're told that a loved one has died, you could actually experience this. Hypovolemic shock results in the inadequate amount of fluid or volume in the circulatory system. Hemorrhagic causes and non-hemorrhagic causes occurs with severe thermal burns. If we lose fluid, whether it be blood, whether it be through like vomit or diarrhea, um, profuse sweating, all of these can cause hypovolemic shock. It's a lack of fluid in the body. The progression of shock. So, stages in progression of shock. The progression of shock, one, compensated shock, decompensated shock. When shock has progressed too far, it is irreversible. No way to assess when a patient has reached this point. Recognize and treat shock early, well before the patient's transition into decompensated phase. So, compensated shock, you can get agitation, anxiety, restlessness, feel of impending doom, weak, rapid, thready pulse, clammy, pale, cool skin, uh, pale or cyanotic about the lips and fingernail beds, shallow, rapid breathing, nausea and vomiting, capillary refill of longer than 2 seconds in infants and children, marked thirst, narrowing pulse pressure. When we hit that decompensated, this is where things are getting really bad. We get falling blood pressure. We'll get that systolic blood pressure of 90 or lower in adults, declining mental status, altered level of consciousness, labored or irregular breathing, ashen, which is that gray color, mottled or cyanotic skin, thready or absent peripheral pulses, dull eyes, dilated pupils, poor urinary output. If we hit the decompensated state, or you arrive and they're already in that state, this is a life or death immediate situation. Compensated, we can work with. Decompensated, it is very serious at this point. Blood pressure may be the last measurable factor to change in shock. When a drop in blood pressure is evident, shock is well developed. Because remember, our body is dilating all of our extremities and stuff. So internally, our heart's speeding up, it's beating harder. We should have that higher blood pressure because we have constriction of the arteries, and our veins, vessels. So naturally, if they're smaller and we're still pumping the same power, we're still going to have a higher blood pressure. When that blood pressure starts to drop, then we know that things are starting to break down or give up. Particularly true in infants and children. We talked a little bit about in class. An adult, you can watch them decline during our assessments, during our treatments. We're going to watch them slowly get worse, 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 worse if they're in shock. Um, where children are going to go along hunky dory and then they're just going to bottom out um, within seconds. When the body's or when the blood pressure drops in an infant, the child's in shock, they are close to death. Also expect shock if a patient has any of the following conditions: multiple severe fractures, abdominal or chest injuries, spinal injuries, a severe infection, a major heart attack, or anaphylaxis. So our scene size up, be alert potential hazards to yourself. So we're gonna BSI, scene safe, mechanism of injury or illness, um, perform a rapid exam, determine the level of consciousness, identify and manage life threats and concerns, determine priority of the patient and how we want to transport, provide high flow oxygen to assist with perfusion. This is a shock patient, remember? So we're going to lay them supine, apply high flow oxygen, non-rebreather at 15 liters per minute, and we're going to cover them with a blanket to maintain body heat. Um, for hypofusion, treat aggressively and provide rapid transport. It is a life threat, so this will always be a rapid transport. Request advanced life support as necessary. Primary assessment, form a general impression, assess the airway to ensure it is patent, assess breathing. An increased respiratory rate is often an early sign of impending shock. Assess patient's circulatory system or status. Um, a rapid pulse suggests compensated shock. They are their body is fighting to save themselves. In shock or compensated shock, the skin may be cool, clammy, or ashen. Assess for and identify any life-threatening bleeding and treat it at once. Determine if the patient is a high priority, if ALS is needed, and which facility to transport to. Trauma patients, such with shock or suspected MOI, generally should go to the trauma center. Where we live, we need to go to the most appropriate or the closest facility. Our closest trauma center is 3.5 hours away. So we will take them um, to the next highest level of care. History taking, determine the chief complaint, obtain a sample history, repeat the primary assessment followed by focused assessment. So remember the difference between trauma and medical. Trauma, we're going to check every single part of that body. We're going to touch it and look at it. Where in medical, we focus on the problem, but we also inspect all other body systems. If a life-threatening problem is found, treat it immediately. Obtain a complete set of baseline vital signs and use monitoring devices. Reassess the patient's vital signs, interventions, chief complaint, ABCs, and mental status. This is one of them that every 2 minutes, 3 minutes. I know the book says every 5 minutes we reassess an unstable patient. When you are done assessing, you reassess. Determine the interventions are needed. Focus on supporting the cardiovascular system. Treat the shock early and aggressively by providing oxygen and keep that patient warm. As soon as you recognize shock, begin treatment. Follow standard precautions, control all obvious bleeding. Make sure the patient has an open airway. Maintain manual inline stabilization if necessary, and check breathing and pulse. As soon as you recognize shock, begin treatment. Comfort, calm, and reassure that patient. Never allow the patient to eat, drink anything prior to being evaluated by a physician. Um, if spinal immobilization is indicated, splint the patient on the backboard, provide oxygen, and monitor patient's breathing. As soon as you recognize shock, begin treatment by placing blankets under and over the patient. Consider the need for ALS. Accurately record the patient's vital signs approximately every 5 minutes throughout the treatment and transport. So we put blankets under and over the patient, determining or depending on where that patient is. So if they're laying on like cold concrete, then covering them with a blanket isn't going to help because they're actually sucking the cold out of that concrete. Um, and I know we haven't got to that chapter yet, but we want to keep that patient as warm as possible. So if that means we lay them on a blanket, if that means that um, the sheet on our cot's a little cold because it's winter out, we can lay a blanket over that sheet before putting them on there because we want to keep them as warm as possible. Patient cannot generate the necessary contractions to pump blood through the circulatory system. Where am I? Sorry. Got this little green thing right in my way here. There. Okay. Treating cardiac shock, cardiogenic shock. Patient cannot generate the necessary contractions of to pump blood through the circulatory system. Patient may present with chest pains. Um, Patients in cardiogenic shock should not receive nitroglycerin. They are hypotensive. Excuse me, I'm sorry. So we talked a little bit about in class about low blood pressure and protocols when it comes to like nitro. If that systolic blood pressure is below 100, we don't give nitro. Um, so that's that hypotensive. We don't we don't want to bottom them out. Patients usually have low blood pressure, weak irregular pulse, cyanosis about the lips under the fingernail beds, anxiety and nausea. Place that patient in a position that eases breathing as you give high flow oxygen, assist ventilations as necessary, provide prompt transport, and consider meeting ALS en route to the hospital. I promise. I just woke up. That's why I'm yawning. Um, For cardiac tamponade, increased cardiac output is the priority. Apply high flow oxygen, and then surgery is the only definitive treatment. All we can do is high flow oxygen, maintain ABCs, and transport rapidly. For that tension pneumothorax, apply high flow oxygen to prevent hypoxia. Chest decompression is required, so go ahead and ask for ALS if you think you need it. If you suspect this, do not delay transport. You can meet ALS en route. Um, yeah. Oh, auscultate lung sounds. If you suspect a possible tension pneumothorax, go ahead and auscultate lung sound and see what you can hear. One side might be uh, quieter or non-existent. Treating septic shock, so hospital management is required. Use standard precaution to transport, administer high flow oxygen. Ventilatory support may be necessary. Use blankets to conserve body heat. Notify septis team if available. I'm going to go a step further and say go ahead and get ALS around here. See if you can get an advance or a paramedic on truck with you because we can start pushing fluids. Treating neurogenic shock. Um, Sorry, I'm in my office and I heard a pickup outside. I was trying to see what it was. Uh, Neurogenic shock, emergency treatment. Obtain and maintain a proper airway, provide spinal immobilization, assist in adequate breathing, conserve body heat, ensure the most effective circulation, and we are going to transport proper or promptly. Treating anaphylactic shock again, administer epinephrine, promptly transport the patient, provide high flow oxygen, and ventilate assist en route. A mild reaction may worsen suddenly. Consider requesting ALS backup if necessary. Um, yes, we don't mess around with these. We've talked a little bit in class about uh, possibly. I just completely lost my train of thought. Um, oh, go ahead and have airway stuff laid out just in case. Have it, you don't have to open it. Go ahead and lay it out on the counter, have it prepared because we could have a complete airway obstruction due to swelling. Sorry about that. I'm treating psychogenic shock in an uncompliant case, uncomplicated case of fainting. Once the patient collapses, Circulation is to the brain is restored. Psychogenic shock can worsen other types of shock. Um, if the patient falls, check for injuries. So these are the ones where you're just going to have syncope. You're going to have fainting time. As soon as they go flat, circulation returns, they wake back up. If they fall, check for injuries. If the patient reports being unable to walk after a fall, suspect another problem, transport the patient promptly. Hypovolemic, so we want to control all obvious external bleeding, keep the patient warm, recognize internal bleeding, and provide aggressive support, secure and maintain an airway, and provide respiratory support, transport as rapid as possible. We're losing fluid somewhere. If you can get an ALS, that's great. We could do some lactated ringers maybe. To help with that, but we want to watch that blood pressure on these, pulse rate, always ABCs. Um, Treating shock in older patients. So older patients have more serious complications than younger ones. Illness is not just a part of aging. Many older patients take medications that mask or mimic signs of shock. Once again, gather our history, do our OPQRST in our sample. Um, I'll go back for a second. Um, Some of them are going to have a lot paler skin. Their circulation is not what it used to be. They're going to be cool to the touch. They keep their house at about 90 degrees. So this is why talking to our patients, reading the room, doing that general impression, that's why we work through our entire assessment on every single patient because each one's going to present a little bit different. The whole point, if you take anything away from this shock, is recognizing shock and treating it promptly. That is like the biggest thing out of this entire chapter. We recognize the signs, which pale, cool, and clammy for the most part. And then treatment is we lay them supine, non-rebreather at 15, and we cover them to maintain body heat. That's the main thing that we need to take away in the real life situation. Is it good to know which each type of shock is and what produces it, what signs and symptoms? Absolutely. That is going to be learned, I feel, over time, seeing it firsthand. That's how I learn. That's I can sit here and talk about these chapters all day long, but recognizing shock and treating it is the main point. The term shock is most accurately defined as B. Yes, shock or hypofusion refers to the state of collapse and failure of the cardiovascular system. It's either the heart, the pipes, or the fluid. Anaphylactic shock is typically associated with hives, the red blotchy areas. Signs of compensated shock include all the following except there's compensated and there's decompensated. I think this one's D. Yep. In compensated shock, the body is able to maintain perfusion to the vital organs in the body via the autonomic nervous system. Signs include all of those, but that weak or absent peripheral pulse, that is decompensated shock. Everything is starting to shut down and give up, so we are not getting that constant good pulse. Our heart's slowing down. We're giving up. Decompensating. When treating a trauma patient who is in shock, lowest priority should be given to, I'm going to say D. Nope, I was wrong. C, splinting fractures. I would have splinted it, but can't get them all right. So, spinal protection, we want to do that. Thermal management, we have to keep them warm. Uh, Notifying the hospital, I'm going to notify them en route, but once again, I was wrong. Splinting the fractures, we want to try to splint fractures before we move them, always, because we can cause more damage if we don't. So, C was the correct answer. Uh, Potential causes of cardiac shock include the following, except potential causes of cardiogenic shock include all the following except. So it's cardiogenic, so it's something to do with our heart, inadequate heart function, diseases of muscle tissue, severe bacterial infection, or impaired electrical system. Hmm. Okay. I'm not going to get another one wrong because I'm not going to say what I think out loud, but see, cardiogenic shock, inadequate. Okay. So bacterial infection, that would be a septic shock. A 6-year-old woman presents with a BP of 80/60, a pulse rate of 110, mottled skin, and a temperature of 103.9. She is most likely experiencing, okay, a septic shock, bacterial toxin. A patient with neurogenic shock would be least likely to present with, so neurogenic. This is the you receive bad news and pass out. You get frightened and you pass out. This is that one. So they are least likely to present with, C, tachycardia, elevated heart rate. A 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. His heart rate is 120 and his respirations are 30. You should treat this patient for hypovolemic shock. He has a rupture of the spleen um, or liver, and he is bleeding internally. He is losing fluid. A 33-year-old woman presents with generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. Her blood pressure is 70/50, or her heart rate is 120. In addition to high flow oxygen, this patient is most immediate need of, yep, a epinephrine. She's had an anaphylactic attack. All of the following are potential causes of impaired tissue perfusion, except A, the increased number of red blood cells would allow adequate oxygen and nutrition to be delivered to the cells. All right, guys, we made it through shock. I will see you on the next one. Let me know if you have questions. I will do my best to help out.